From Washington, D.C. and around the world, this is Government Matters Thought Leadership Network with Mimi Geerges.
Welcome to Health Equity, sponsored by KPMG. For the Government Matters Thought Leadership Network, I'm Mimi Geerges. COVID-19, natural disasters, and racial discrimination have all led to the public and private sectors taking health equity more seriously than ever before. It's the concept that every citizen should have the opportunity to achieve their full health potential, regardless of social circumstance. But systemic, historic, and economic factors can impede the delivery of equitable access to quality health care. In this 30-minute program, we'll explore the challenges and key resources, tools, and expert personnel that will enable the federal government to act now and deliver lasting results. Joining me now is Dr. Ernest Moy, Executive Director of the Veterans Health Administration Office of Health Equity, and Dr. Eliseo Perez-Stable, Director of the National Institute on Minority Health and Health Disparities at the NIH. Gentlemen, welcome to the program.
Thank you.
Dr. Perez-Stable, I want to start with you. What is the definition of health equity, and is there a consensus on that definition?
So, health equity hasn't had a operational definition like we have had with health disparities. Health disparities is in our title and it's in legislation, and it really focused on differences compared to a reference population. Usually the majority population are whites in the case of race and ethnicity. But recently health equity has gotten more popular, and yet we haven't really settled on what it means. Ideally, it's the principle that everyone can achieve their maximum health based on all the individual and social and structural factors that influence that health. But we haven't figured out, well, what's the standard? And I believe that one of the things that we can do is say, well, here's the goal for the entire country. How can we reach that goal? Like in Healthy People 2030 sets goals. Can we get to 90% of that, 100% of that, or not? Because if we just compare race ethnicity, for example, Asian Americans and Latino Americans are already better off than whites. So we have to recalibrate our definitions in that regards.
And Dr. Moy, inequities in health have always been a problem. Why that renewed focus? Why the increased attention now?
Well, we've known about these problems for a very, very long time. Eliseo and I have worked on these problems for a very, very long time. And over that time period, I think things have changed. I know certainly when I first started working on this, there was a lot of resistance to this particular concept, whereas I think this concept is fairly well established. I also think that COVID really brought out these health inequities in very, very sharp contrast. Instead of, the usual inequities we see impact people's lives over months or years or decades, under COVID, we saw it impacting people's lives in the course of days. Right? We saw differences in rates of infection. We saw the differences in outcomes of those infections in very, very real time. And I think this really highlighted for many people outside of us, because we've known about these problems, the really importance of this particular concept for maximizing the health of Americans in general and for us, for veterans.
And Dr. Perez-Stable, what would you say is the current state of health equity? What are the biggest issues that you're seeing?
The biggest issue from my view is structural factors, and acknowledging that it's not just individual behavior that leads to bad health outcomes. It's not just inadequate or poor quality health care when you get sick, but actually if you put someone in a living situation where they don't have access to healthy food, they don't have green space to be able to do physical activity, and they're living in crowded conditions, working 2 jobs in order to make ends meet, how can we expect them to have good health? And these are factors that begin to affect our lives early on, and they're cumulative. So maybe in childhood you don't see as much, but by the time people hit 40, you begin to see this burden of chronic stress exposure from these factors, as well as the issues of discrimination.
And Dr. Moy, the VA is a closed medical system. All vets are eligible for care. So what disparities are you seeing?
So in our system, vets are eligible for care. There are some differences, and not all vets are eligible for all the different kinds of care that we have. But I will say that we think that we can get services to the people who need them the most. And even as we are getting services to our veterans, we find that the outcomes are still not the same. So when we look at something like care for diabetes, we track that in great detail, and we can see there are very few differences in the processes that different veterans receive related to sex, race, ethnicity, where they live. We can actually deliver services fairly effectively and evenly distributed. But what we see instead is that the outcomes of that care, that high quality care, can vary across different populations, and that's where we're at. That's what we're trying to change now. We think a lot of it has to do with not getting people the right services, but the context of that, how we're delivering those services. Do they understand what we're trying to communicate with them? Does that resonate with them? Can they do the things we're asking them to do? Because different veterans are in different circumstances. And what we're trying to do is to customize the advice that we give so that each veteran can do the things they need to optimize their health.
And Dr. Perez-Stable, Dr. Moy had mentioned COVID. What did you see? What were the big issues that you faced at the height of that pandemic, and what new initiatives might have come out of it from the NIH?
So 2020 was quite a year.
It was quite a year for everybody.
I would say that looking back, one of the things we didn't talk about was the fear that we all had of what was going on. I think at NIH, Dr. Collins led us in mobilizing everyone's talents to say, what can we do? What can we do now? What could we do yesterday? I think the biggest lesson for me was, first, these disparities became stark and obvious to even the president at the time, because it was just so clear that African American communities initially, then Latino communities, American Indian communities were hammered by the pandemic in a way that no one had predicted. No one had predicted this. No matter how much we, oh yes, we thought this was going to happen. No one really thought it was going to happen.
And why is that?
It was the people who were doing the work, the FaceTime work, you know, the frontline workers. They couldn't stay home and do Zoom, right? They had to go to work, and they were exposed. And they also were living in crowded conditions, frequently 2 families in one building, in one apartment. So they could, you know, tell them, isolate if you get exposed. Well, there's 1 bathroom for 8 people. How can we isolate? And these realities were stark. Because at the time we had no vaccine, no treatment. We just were figuring out what to do with it. A second point, though, that I think was really important was the really central importance of community engagement. We had to go into the community, get the trusted leaders in the community on board with the scientific message. Because great vaccine, okay, it works, but we couldn't get people to take it initially. The uptake was in different populations. It took a little bit to get there. We have gotten there. And it showed that you could get similar vaccination rates for the populations. And in fact, at least until the most recent increase, which I don't know the results of, the adjusted death rates are now pretty even for blacks, Latinos, and whites. And I think that's a real lesson, a real accomplishment of our efforts.
And Dr. Moy, let's talk about vaccine hesitancy, which did show up, obviously, in certain groups, which is understandable given the abuses of the Tuskegee experiments and things like that in the past. How do you overcome that? What did you learn about overcoming that hesitancy?
Right. So it's the nice thing about the VA is that we are a healthcare system, but we're also a broader system. And so we have researchers and we have health educators that work with us intimately. And one of the things that we did at the very start of the pandemic, so in March of 2020, we set our researchers, we pulled them off all the projects they were working on and said, okay, you got to work on COVID. And one of the things we asked them to do was, okay, find out what happened during past pandemics, right? We're concerned about disparities. In that first month, more than half of the cases at VA were among African Americans. And we said, this can't happen. We need to stop this. We need to nip this in the bud. And so we set our researchers and they looked at swine flu, what happened during swine flu. And we saw exactly the similar patterns that were coming up, right? Our minority veterans, minority people were a lot more likely to be exposed. They had higher rates of infection and they were experiencing ultimately vaccine hesitancy when a vaccine became available. And so we said, okay, we need to make sure that does not happen for our veterans. And so during the summer, even before vaccine was available, we applied our special sauce. Our special sauce is our veterans. And so we asked our veterans, what do we need to do? What do we need to say to get you to get the vaccine when it actually becomes available? We convened groups of minority veterans, and we asked them this very specifically, and they told us that we needed to be transparent and we need to be trusting. And those aspects, I think, were built into all the materials we put out there.
Give me an example of transparency.
Sure. So the first thing is we need to actually talk about data, not rhetoric, right? Give them the right to make that decision for themselves, not say this is what you need to do. This is, but also say we're trying to communicate this information to you in a way that you have everything that you need to make a good decision for you and for your family, but it's your decision. And that included, for instance, for our minority veterans saying, oh, okay, you know, this has been widely tested among people, the vaccines, when they actually came out. It's been widely tested among all minority groups. This should work for you. You know, we have every expectation that's the case. The other thing was the trusting aspect, and many of our minority veterans told us you need to be upfront with past problems that have existed with the federal government. This is, you know, a new medication, so you have to go and talk about Tuskegee with our African American veterans. You have to talk about other kinds of abuses with other minority veterans up front. And so when we put out materials for our African American veterans, and that's one of the decisions was to customize materials, so materials for different groups. That material began with Tuskegee. This is not like Tuskegee. Tuskegee, they were withholding information for people to make good decisions. Here we're trying to give you all the right information so you can make the best decisions for yourself. So that's some of the strategies, and I'll say that we never saw a problem with vaccination among our minority veterans. From the first day, minority veterans have been vaccinated at a higher rate than white veterans have been. And we think it's this intentionality. You know, what do we have to do to get there? Tapping into our veterans, our special sauce, and then listening to them and making our materials have those features that they recommended to us.
And Dr. Perez-Stable, you know, the federal government through the NIH funds a lot of research, clinical trials. What's the current state of representation of minority groups in that research?
Right. The NIH funds about a third of the drug trials that get conducted at most. And in the NIH clinical studies, and looking at all clinical research, where humans are involved, let's put it that way, about 30% of the participants are racial and ethnic minority persons. So we're not at demographic representation, and we're kind of stuck at that 30%. So we're now looking with the Secretary's encouragement at what will it take to get us up higher, to closer to the 40% of demographic representation.
So what will it take? I mean, what are your ideas? My
ideas are first that each investigator needs to report what they plan to include in their study. That's required by law. So they have to send a table with their grant proposal that says this is how many men, how many women, the age groups, the race and ethnicity. That we get that. They have to also have a plan. How am I going to get to the people that we don't usually recruit through normal mechanisms? We discovered that with the vaccine trial, with the Moderna trial. So going to a website and signing up was not going to get too many diverse participants in the Moderna trial. It took a plan, a different approach, getting local leaders engaged, and modeling, you know, yes, I'm going to get my vaccine as a family doctor, an African-American family doctor in New Orleans, as a very powerful message to that community, as opposed to just go to the website because we've got a great product for you. That's one thing. And then monitoring that plan, being able to have diverse investigators that know how to reach those communities, and then making the investigators accountable in some way. We haven't figured all of that out, but this would be the ideas that we would propose.
You know, another big issue, though, Doctor, is rural Americans that, frankly, just live too far away from good quality health care. There's also a crisis of rural hospitals closing in the country, all around the country. So what do you do about that? What are your ideas to address that?
So Americans who live in very remote rural areas are a special group. It's about maybe 5 or 6% of Americans live. And telemedicine, actually the biggest budget item often is flights to get people out when they're really sick. You can't get physicians to stay in those areas, so that's a special challenge that we do need to address that from a service orientation. And then there's a larger group of Americans that live in more rural areas, not in urban or even suburban areas, and that group also is more remote. You know, you drive 50 miles to go buy food. That's certainly not the same as living in a city or in a suburban area, and those are challenges that we haven't resolved in that regards.
Dr. Moy, what about you? What about veterans that live too far away from one of the VA's health centers?
Right, and veterans are more likely to live in rural areas than your average American, so it is a very big problem for VA. We do commit a lot of effort to try to ensure that they can get the care that they need. We have long-standing telehealth services that are available to all of our veterans, but these are particularly useful for rural veterans. And we have a whole digital divide consult service that tries to go out and speak with our veterans, in particular rural veterans, and identify what digital challenges they maybe have. Maybe they don't have devices, maybe they don't have Wi-Fi, maybe they don't have internet, maybe they don't have bandwidth. And there are ways for us to address many of those issues, and we try to intervene for those. Again, we're more than a healthcare system, so we give veterans iPads so they can communicate with us. We get them discounts on their Wi-Fi. We have negotiated with carriers so that when they connect with us through our server, it's not counted as data. It's just a phone call. We also do a lot of other things that are specials. So we send out a van to very rural areas. We have partnerships with Walmart and with different veteran service organizations like Veterans of Foreign Wars to set up modules in their particular facilities so that rural veterans can go there and communicate with us securely.
Well, speaking of the digital side, data analytics is big in every field. What kind of data are you collecting in your effort to identify those health disparities and address them?
We're a massive healthcare system, and we, I think, have one of the oldest electronic health records that exist out there. And so we have decades and decades of information on many of these veterans that we then try to apply to optimize their health. And we do use algorithms as part of that. These algorithms require the good data, and I will say that our data in particular as it relates to disparities are excellent. We have racial and ethnic data for over 90% of our veterans, which we think is very good compared to the outside. And this gives us good inputs into these algorithms. We have a number that are interesting. We have an algorithm to identify veterans at higher risk for suicide, a big problem for us. We have an algorithm that identifies veterans that are at higher risk for adverse outcomes from opioid addiction and other adverse complications. We have to have veterans on these medications, but we want to know who's at higher risk. These algorithms are all subject to a problem that I think that's important to recognize, which is algorithmic bias. So these algorithms are developed from data on everyone, but they don't work as well for everyone sometimes. And so one of the important things is to go back after we develop this machine learning and this algorithm and look to see how it's working for each group of veterans and making sure that it works well.
Dr. Perez-Stable, what about you and the use of artificial intelligence, machine learning in what you do?
So data science is a critical area that we need to develop more. And there's very few underrepresented minorities that have entered the field in engineering or in data science, and this is an area we're very interested in. We're not providing service at NIH, so we're mostly in the area of research. So the electronic health record is, in many ways, a gold mine for research. But it's the quality of the data has to be standardized and harmonized. So if I collect race, ethnicity, or socioeconomic status one way, and my friends in New York collect it another way, it doesn't help. And that's frequently what had been happening. So we're getting closer to harmonizing common data elements, really having people use the same measures to evaluate the demographic and social factors. The clinical factors get produced through a lab, so those are more standardized. But I think we're getting closer. There's also population data. The American, the decennial census and the American Community Survey done every year is a wealth of information on Americans. And I think linking that to other data, whether related to environmental factors or clinical factors, I think is another way of getting more research done. But we need more data scientists, for sure.
All right. Well, doctors, thank you so much for being on the program. Nice to talk to you.
Nice to talk to you. Thank you.
Thank you.
You're watching Health Equity, sponsored by KPMG on the Government Matters Thought Leadership Network. To learn more about the work of the Veterans Affairs Office of Health Equity, visit va.gov/health-equity. For more about the National Institute on Minority Health and Health Disparities, visit nimhd.nih.gov. Coming up in our next segment, we get an industry perspective on the causes of health disparities, the current state of increased awareness of the issue, and why addressing health equity and creating a healthier population is good for the federal government, business, and communities at large. KPMG Advisory Services has created numerous resources, including a white paper on building momentum toward health equity. You can find that at advisory.kpmg.us. Then search for health equity.
Health Equity is sponsored by KPMG. Learn more at read.kpmg.us/modgov.
Welcome back. Joining me now is Megan Hendry. She's an advisory managing director at KPMG. Megan, welcome to the program.
Thanks, Mimi. Glad to be here.
So I asked this question in the previous segment, which is, why is health equity having a moment right now?
Well, I think a couple of things. You heard in the last segment around COVID's impact on that. I think it really served to surface some of the longstanding inequities that have been persistent for a long time. But we're also seeing a confluence of other factors, including a broader social justice movement right now, as well as sort of the ESG focus for corporate America, which is environmental, social, and governance. And what that means is that companies are starting to pay more attention to things like health equity because consumers are starting to decide where they want to spend their dollars based on how companies are responding to this moment.
I wanted to ask you about that because it's not just the government that's paying attention, it is the private sector. So beyond this being the right thing to do, is there a business case for health equity?
Yeah, absolutely. So more broadly, we see a huge impact in excess medical costs, so almost $100 billion in excess medical costs. We're also seeing big impacts of lost wages, so almost $50 billion in lost wages. So the financial impact to these companies is significant, and as I mentioned, really consumers are starting to make some differentiated choices on where they want to spend their dollars.
So what would you say are the main issues causing health disparities?
So this is one of the more challenging aspects of talking about health disparities or health equity, which is that these are long-standing systemic issues. So there is no one thing that's causing this, and as I think you heard in the previous segment, there's a multitude of factors. So it absolutely relates to people's access to healthcare, but it also relates to where people live, the opportunities they have, access to healthy food choices, access to stable housing, lots of impacts overall, which make this a pretty difficult problem to tackle, but very important.
I want to ask you about the impact of climate change on vulnerable populations. There's also the issue of environmental justice. Can you spell out those two issues for us?
Sure. So climate change is more broadly talking about the impact of what's happening to our climate, which we're seeing all day, every day in some cases, and certainly more recently. Social justice really talks to the aspect that the impacts of climate change are not felt and experienced equally amongst the entire population. So vulnerable populations who are already experiencing increased risk and increased disparities are feeling the impact of climate change much more severely. So that's really what environmental justice is talking about.
So what can the government do to have the biggest and the quickest results?
Sure. So I think, the focus right now is incredibly important. I think the conversations that we're having are very important. You heard in the last segment the importance of data, gathering data, using standardized data to really understand where we're seeing inequities and how to move forward. And I think really championing the movement to capture sort of the winds of change that are really flying around right now.
But you said this, you said it's not time for baby steps anymore. It's time to kick the doors down. What does that look like?
Well, I think it really looks like capitalizing on this moment. And so really, because these are very longstanding issues, and as we've talked about, these aren't new, there have been lots of effort over the last decades to try to move the needle on health equity. And so given that health equity is sort of having this moment where folks are paying attention, there's dollars behind these efforts, this is really an opportunity to capitalize. And so practically what that means and what we talk to our government clients about is sort of more bang for your buck. So where are you already moving from a strategic perspective that you can bake in these conversations and questions around equity and disparity to make sure that you're really making some fundamental changes?
You have something called the Health Equity Framework. It's comprised of 3 nodes. Tell us what those 3 components are.
So the 3 nodes of our health equity flywheel are learn with, design with, and act with. And this is really based in literature and evidence. And as you heard in the previous segment, there's a lot of good anecdotes around what works in terms of engaging communities. And that's really what we wanted to use as the foundation of the flywheel. And fundamentally, it's about co-creation. How do you bring in the communities that you're trying to impact into understanding the problem and then designing a solution for that problem and then implementing a solution that's likely to make a real impact and a change in people's lives?
Give me an idea of what you tell government clients to do, specifically the HHS or other agencies like that, as far as being more creative when addressing this topic.
Yeah, so what I would argue is the hardest part of the flywheel is that design with, and that's really about that co-creation conversation. And so in order to be most creative, I think it's most helpful to listen to the communities and understand what has the greatest impact. And so, as you heard in some of the conversation around vaccine hesitancy, really understanding where communities want to get their information from, who are trusted advisors to that community, what other parts of the ecosystem are acting with that community. That is really where I think the creativity comes from. And I also think, and this is borne out by the evidence, that's where the lasting change comes from.
You know, health disparities is no longer just about race. There's a lot of other issues involved, like homelessness, like broadband access for telehealth. There's a lot going on. Can you talk about all those issues and how do you not get overwhelmed with how big the problem is?
It is a big problem. And so traditionally we've talked about those other elements as social determinants of health. And so as we talked about, those are things like your access to education, safe housing, healthy foods. And it is easy to get overwhelmed. And that is one of the challenges of tackling this problem. On the flip side, and maybe on a slightly more optimistic note, it does mean that by acting in almost any direction, you can have an impact. And so really it's about looking at the interconnection of these moments, these points, and using the momentum in any one of these areas to really be a catalyst for better equity.
You know, as we heard in the previous segment, there's a lot of advances going on and new initiatives and exciting things going on. But how do you make sure those advances stick and don't just go away when the administration or Congress shifts focus?
So the good news story here is that despite what might feel like very different rhetoric, the focus on making sure that citizens of this country have access and fair access is something that's been a focus for a long time. And so I think that's something good that we can continue to focus on. What I would say is that the best outcomes are when we embed our focus on equity and reducing disparities into our broader work. And so how, for our government clients, how is where you're moving strategically for your programs and your policies? How can you think about sort of baking in that lens on an ongoing basis so that these aren't sort of one and done projects, but instead really become a fabric of how these agencies function?
And I guess, wrapping up this program is the question about this moment that we started with. And is the moment fleeting? Is it here to stay? And what, can the public and private sectors really make a difference, a lasting difference?
I think it is here to stay. I mean, as we mentioned, these are long-standing issues that have been a problem for a long time, but these are also things that have been being worked on by a broad swath of professionals for a very long time. So even though sometimes how much we talk about it or how much it might be in the news or we're seeing headlines about it, I do think that this will continue to be an important focus area and will have some longevity. And I think really taking that approach of deciding how you can incorporate these lenses and this awareness into your broader programs will be the path to making sure that these are longstanding and impactful changes.
All right. Well, Meg, thanks so much for being on the program.
Thanks for having me.
Thanks for watching Health Equity, sponsored by KPMG. For more information, go to govmatters.tv/health equity. For the Government Matters Thought Leadership Network, I'm Mimi Geerges.